All right, and with that, we'll get started. So welcome everyone. February is turning out to be a nice surprising month, although in the other group we talked about how much we despise it, so thank goodness it's short. Welcome to the February Ability Grand Rounds with the CED, and I'm excited to introduce Dr. Farmer, who's our guest speaker for Grand Rounds this month. Thank you for going ahead and having your slides up. Again, she's talking about differentiating ID and ASD in terms of measurement. So Dr. Farmer, a lot of people on this call provide a variety of services to individuals who meet one or the other type of disability. And so we're interested in your work. Just a quick background, and then I'll turn it over to you, if that's okay. Dr. Farmer currently works at the office of the clinical director at the National Institute of Mental Health. She does research in clinical psychology, developmental psychology, and psychometrics. Her most recent publication is, and this might be a little outdated, but features of dissociation differentially predict antidepressant response to ketamine in treatment-resistant depression. That might have been an older one. And so we look forward to hearing your work as a whole. And with that, I'll turn it over to you, Dr. Farmer. Thank you.
Great, thanks. Yeah, I'm a psychologist, but in my day-to-day life, I sort of function as a statistician, and so I work with a couple groups, and one of them is a group that studies the use of ketamine as an antidepressant. So not my content area, but I help them out with their analysis of clinical trials. So my CV always looks a little funky. As Dr. Cottrell mentioned, I am in the intramural research program at the National Institute of Mental Health, and I work in a group called the Neurodevelopmental and Behavioral Phenotyping Service. You probably can guess what we do from that name, but really what we spend most of our time doing is collaborating on protocols from across the intramural research program, not just from NIMH. And in fact, most of our protocols have to do with the NHDRI or NICHD. But as long as they involve neurodevelopmental disability, we are involved. And most of our current work is focused on the phenotyping of rare genetic conditions. And as we are going to discuss momentarily, severe intellectual disability is more common in these populations with rare genetic conditions. And so our group spends a lot of time thinking about intellectual disability and specifically measurement issues associated with intellectual disability. And so today what I'm going to be talking about is drawn largely from a recent paper that we published on this topic. And this paper was written with a couple of my close colleagues, and we have a long-standing collaboration on projects related generally to behavioral measurement in neurodevelopmental disabilities. And I sort of bring the statistical and psychometric expertise to the table, but Drs. Audrey Thurm and Summer Bishop really are the clinical brains of the operation. And so I want to emphasize that I'm going to be talking a lot from a psychometric perspective, but I'm going to sprinkle in the clinical perspective, which is largely coming from these two folks here. So today, what I'm going to cover is, broadly speaking, the issue that psychometric and clinical issues really can't be disentangled. And what I hope to convey to you is that clinical judgment really is irreplaceable in the assessment of neurodevelopmental disabilities, and that a big part of clinical judgment is understanding the limitations of the tools that you're using. And we have systems in place to help us make valid judgments, and we'll discuss some versions of that. But I want to leave you with a sense of kind of skepticism about the instruments that exist to support these systems and some idea of how to gather the necessary information that you need. So first, I think it's useful to review the concept of intellectual disability. So when I speak to more general groups, I assume that most people know almost nothing about intellectual disability, which I will refer to as ID. Of course, you guys probably know more than the average group about ID, but I have found that even among professionals in the neurodevelopmental disabilities, It's common to have little formal training in the assessment or intervention of ID, and even less common to have regular interactions with people who have more severe forms of ID. So I'm going to just put us all on the same page here and review the diagnostic criteria, some basics of assessment, and then talk very briefly about the epidemiology. So intellectual disability, of course, is multifaceted and complex. It comes in a wide range of clinical presentations, but has, for at least for the past 50 or so years, been defined by 3 longstanding criteria relating to significantly sub-average intellectual functions, significantly sub-average adaptive behavior, and onset of those deficits occurring during the developmental period. This is true of both major diagnostic systems. So, you know, you can be diagnosing this with DSM or with the American Association for IDD criteria. But I think it's important to note here that this is a behaviorally defined disorder, and that really means that the etiology is irrelevant for the diagnosis, except to the extent which is implied by that last criterion, that this needs to have onset during the developmental period. So, of course, if we see these symptoms A and B, but it's the result of something like head trauma or disease happening outside of the developmental period, of course, we're looking elsewhere in the DSM under, you know, neurocognitive deficits. And so what I want to highlight here is that the diagnostic guidelines explicitly require the standardized measurement of intellectual functioning. And this might not be as straightforward as it seems. And so we've arrived at talking about measurement already. And so when we think about standardized assessment in intellectual disability and how it's required, we know that the scales that we use for this are pretty effective at identifying whether someone has significantly sub-average cognitive ability. And strictly speaking, that's all that you need to know for a diagnosis. But clinicians and researchers, of course, are interested in the degree of impairment in intellectual function. And unfortunately, when we are talking about moderate to profound ID, the standardized assessments are really inadequate. They really leave a lot to be desired. So first, it's important to note that the reliability of a standardized test decreases as a function of distance from the average. And so that's just a result of how standard scores like IQ are developed. And it really just means that there's more measurement error when we are talking about somebody, you know, with an IQ around 60 than for somebody with an IQ around 90. This is a symmetric limitation. So the same is true if you were assessing somebody who has a much higher than average score as well. And so when test developers tell you that the standard error of measurement for their scale is about 5, which is what most of them are, it turns out they're fibbing a little bit. They're giving you the average number when in fact it's much larger when we're talking about lower scores. So when we think about a confidence interval around a score of an IQ score of 50, it actually in reality is much wider than the confidence interval that we would estimate for somebody with a score of 100. And publishers they're aware of that, obviously, they developed them. They know about this lack of reliability, and that's why the IQ scores traditionally stop at 40, because that's 4 standard deviations away from the mean. And, you know, depending on the content of the test, the publishers could provide you with lower scores, but the degree of unreliability in those scores would make them somewhat meaningless. And so the publishers just sort of stop at saying, well, the score is less than 40, and that's all you need to know. And so that phenomenon where people with a range of ability get binned into the same IQ score is a floor effect. Sometimes, though, that floor effect occurs because the test is too difficult for the participant. So imagine using a calculus test to assess math abilities of 3rd graders. They're all going to get 0, right? But of course, that's obscuring any variability that there really is in math ability in that sample. The calculus test just wasn't developmentally appropriate. And for people with moderate to severe ID, the test that's appropriate for their chronological age is often like that calculus test. It's just inappropriate for their developmental level. And there is no standardized intelligence assessment that covers the full age range and the full range of ability. And so one solution for this issue that we use and that we've written about is to use a testing hierarchy where the appropriate test is selected based on both chronological age and developmental level, And of course, this requires some non-standardized assessment sometimes, or being flexible with particular aspects of standardization. And that's why the specific clinical training in developmental disabilities is so important. But when a norm reference scale is used outside of the age range it's intended for, we can't then use the standard scores, the norm reference scores. And so instead, we have to calculate the ratio IQ, or what we tend to call the developmental quotient, which is the old school definition of IQ, that mental age over chronological age. But of course, there are some problems with that. So chronological age has a pesky habit of increasing every minute, whereas our cognitive ability, even in perfectly healthy people, tends to plateau and then start decreasing at some point. And what that means is that ratio IQs do tend to falsely deflate over time, which was kind of why IQ scores were developed in the first place. And that means that we have to be careful when we're interpreting ratio IQs. But a poorly kept secret is that when we are talking about people with intellectual disability, even if we're able to get a standard IQ, it turns out that those IQs tend to decrease over time as well. Not because people are losing ability, but because people are starting to look worse compared to their peers, which of course is what an IQ score is telling you about. So we really need to consider the limitations of standardized tests even when we're using it consistently with standardization. So the other limitation of this hierarchical approach to getting a standardized estimate of ability is that different measures don't always yield similar estimates for the same person. So this is true between tests. I haven't shown you here, but we demonstrated several years ago that Mullen and DOS estimates of IQ. So these are tests that some of you are, I'm sure, familiar with, that are used, developmental tests that are used to estimate cognitive ability in young children. Those estimates differ by about 20 points within person. But you might also be surprised to learn that the estimates, even within the same person at the same time, can be really different between editions of a test. So here I'm showing you some work we did with the Vineland 3 and the Vineland 2. This is a measure of adaptive behavior, and you can see pretty big differences. And so when we are using this hierarchical approach, there are these limitations to interpretation, but our ability to estimate the sort of degree of intellectual functioning with some precision is probably worth these limitations, at least until some better alternative arises. Because as we're going to discuss later, having a good sense of someone's functioning allows for more valid interpretation of other behaviors like their autism symptoms. And so the second criterion of intellectual disability, sub-average adaptive functioning, is arguably the more clinically relevant one. And that's why it's adaptive function and not cognitive function that drives the severity specifiers that we have available for an ID diagnosis. To say somebody has intellectual disability really isn't enough. We could be talking about somebody who can learn practical life skills and just needs a little bit of support to maintain independence. Or we could be talking about someone who needs around-the-clock one-to-one care and cannot under any circumstances live independently. And so I want to emphasize that these different severity levels have different diagnostic codes for a reason. They really are like different disorders. So it is the more severe end in which my collaborators and I are really more interested in. And so, for most of this talk, when I say ID, what I mean is moderate to profound ID. Now, mild ID is obviously the most common. Sometimes you'll hear people talk about the etiology of intellectual disability as being either familial, cultural, or organic. And the distinction is that the familial or cultural runs in families while organic does not. That distinction is not 100% accurate, but it's pretty useful because more severe forms of ID tend to be organic, which is to say that they tend to result from de novo mutations or environmental insults. Or if they are inherited, they tend to be recessive so that siblings and parents are typically not affected. And it's usual to think of intellectual disability as kind of existing at the end of a normal distribution. And so here I'm kind of illustrating with my shaky drawing there that just like IQ, although of course adaptive behavior factors in as well when we're thinking about ID, the reason why normal distributions are so common in nature is because any process that adds together a bunch of random fluctuation ends up having a normal distribution. So most things in nature have an uncountable number of causes. And the end result is that some individuals are higher than average, and in symmetric magnitude, some individuals are lower on whatever construct we're talking about. And so when we think about IQ, we have this sort of normal distribution in the population because of all the influences on something like intelligence. And so if we're considering a general intellectual disability sample, most of them are going to have IQ in kind of the mild range, some with moderate and very few with severe or profound, because we're talking about the tail of a distribution. But among people with rare genetic conditions associated with developmental disability, the people that I study mostly, we expect a much more even distribution, or in other words, much more representation of severe and profound intellectual disability. That's because these genetic events are so influential that they sort of override all the other determinants of IQ, and they effectively knock a person off of that normal curve and onto what some refer to as the bump of pathology, where perhaps there is a symmetric distribution, but it's shifted far to the left. And so moderate to profound ID is more common among people with rare genetic conditions, and the converse is also true, that rare genetic conditions are more common among people with moderate to profound ID. Now, if you're a person who studies autism, this matters to you because rare genetic conditions have increasingly been the target populations for autism research. And so this question of what autism looks like in people with moderate to profound ID is really gaining prominence among a broader group of researchers and clinicians who are not usually studying this population. So I've reviewed the diagnostic criteria with the purpose of sort of motivating this question of differentiating ID from autism, or really of diagnosing autism in the context of ID. So we've established why it's important and relevant, but I think it's worth having some explicit discussion about why it's so difficult. When we look at the relevant data that we have, like on the left, you're looking at educational diagnoses for intellectual disability decreasing over the years, and autism educational diagnoses increasing. Or on the right, we see these relatively high rates of likelihood of autism diagnosis in genetic disorders that were previously thought to be primarily associated with intellectual disability. These data points really suggest that there is some diagnostic substitution happening out there in the research and clinical world. And so it's worth considering why that might occur. So as for most behaviorally defined disorders, the behaviors that we think of as being the indicating autism are not specific to the disorder. So this overlap is well acknowledged. I mean, the DSM has criterion E, which I've highlighted here, which specifically states that if you're seeing these symptoms, but they're explained by intellectual disability, then the autism diagnosis really isn't appropriate. And functionally, what that means is looking at the context or the broader picture of the individual. And so an even profile where the abilities in the social domain are consistent with what we would expect based on the cognitive domain, then we're thinking intellectual disability. But with autism spectrum disorder, we're looking for social abilities that are less than what we would expect based on the person's cognitive ability. Or in other words, social deficits that exceed their cognitive deficits. The trick there, of course, is knowing what social ability should be expected for a person given their cognitive ability. So as you can see in this chart, there's been a lot of thought put into what sorts of social impairments we see at different levels of cognitive ability. And the reason why people have thought a lot about this is, of course, that the social domain is part of adaptive behavior, which is one of the diagnostic criteria of intellectual disability. So a person with severe intellectual disability might not have a lot of spoken language and may only understand simple speech or gestures, and isn't going to have a lot of close relationships with people who aren't family members. If we observed those features in someone whose cognitive abilities were in keeping with their chronological age, someone who doesn't have intellectual disability, then that particular profile might suggest autism. But in somebody who has ID, where it's consistent with their cognitive abilities, we just sort of say, okay, well, that looks like that's accounted for by the intellectual disability. And so when we're thinking about somebody with intellectual disability, we need to consider what sort of social abilities we would expect from them given their mental age. And this gets really tricky because we have to consider the fact that first of all, development is uneven much of the time in neurodevelopmental disorders. And so we really shouldn't assume that someone who has intellectual disability and has a particular mental age is going to look identical to a typically developing person with that mental age. And we also cannot discount the effect of learning. So if we're talking about, you know, a 7-year-old with a mental age of 13 months, that person has had, you know, 5.5 more years of learning than a 13-month-old with a mental age of 13 months. And that learning is definitely going to impact modify the presentation of those behaviors. And so this really underscores the need for a really full and thorough assessment of the individual with intellectual disability in all domains of behavior in order for the clinician to really have a complete understanding and be able to interpret the social behaviors and social deficits relative to the person's general level of ability. So mistaking ID for autism can affect the validity of our research. And I think, you know, those of us who study rare genetic conditions would argue that it is affecting the validity of our research. So many of the disorders that are being studied as autism disorders or autism genes are actually more strongly associated with intellectual disability. And so the potential for diagnostic substitution at work there really muddies the water. A lot of what we do in our lab is centered around treatments for specific genetic conditions, and the technology has really advanced enough that with mechanism altering, or that, you know, there is the possibility for mechanism altering interventions. And so in that context, it's really important that we have valid measurement of our target outcome. If we think we're measuring autism symptoms, but we're actually measuring symptoms of intellectual disability, then we might miss a signal. And finally, clinically, you know, we also think about the point of a diagnosis being to convey information to other professionals about prognosis or about appropriate intervention. And so the extent to which those two things differ between ID and ASD is going to impact how big of a deal it is to substitute the diagnosis, which, you know, raises the point that sometimes it might not matter. Sometimes this distinction between autism and intellectual disability might not matter, because from a clinical perspective, it may be true that a given intervention is appropriate regardless of why, you know, in what context the behavior is occurring. So a primary example of this, of course, is applied behavior analysis, which was developed in the intellectual disability literature, but, you know, has really been focused on in the autism literature, and in a lot of places, unfortunately, is not paid for by healthcare plans unless you have an autism diagnosis. So in that respect, you know, there may be times where this distinction actually doesn't matter all that much. All right, so this kind of brings us to discussion of the psychometric characteristics of the measures that clinicians and researchers are using to make the diagnoses, and specifically whether these measures are sufficient for diagnosing autism in the context of intellectual disability. And so I'm going to spend a few minutes reviewing basic principles, but then I'm going to extend into a sort of more nuanced understanding of the psychometric profile. And I hope you'll see that each of these things is going to be relevant for us to understand the inadequacies of the tools that we have for autism when we're thinking about samples with intellectual disability. So, of course, any conversation about psychometric properties has to start off with the concepts of reliability and validity. I'm not going to belabor these points because I know we're all sort of familiar with the general concepts of reliability and validity. Reliability, of course, we're talking about consistency. So assuming that whatever I'm measuring hasn't changed
the score shouldn't change either. When we're talking about validity, we're talking about what we're measuring. So am I measuring the thing I think I'm measuring? But what you might think about less often is the sort of broad range of ways a measure can be reliable or valid. So there are lots of different types of reliability or validity beyond just the kind of like convergent and divergent that you learned in school. And these are relevant for your purposes depending on what you're doing with it. And so what I want you to take away here is just the idea that it doesn't make sense to talk about a scale being reliable or valid as if it's a property that's inherent to the scale. There are many, many different types of reliability and validity, and the extent to which it is exhibiting adequate evidence depends on the studies that were used to generate it. So let's talk about one specific type of validity, which is obviously relevant to the diagnostic discussion that we're having, and that's sensitivity and specificity. So when a measure makes a yes or no decision, we are first, of course, thinking about the sensitivity of the measure, which is, you know, how many of the people who have the disorder get a positive test. And secondly, we're interested in the specificity, which is kind of the converse. So how many of the people who do not have the disorder get a negative test? You guys know the drill with sensitivity and specificity. But what I want to highlight here is that both of these properties of a scale can be important in different ways, but we have to consider both of them because a test can be 100% sensitive if it classifies everyone as positive. That's not actually very helpful. And typically we're looking for some sort of a balance of sensitivity and specificity depending on the setting, depending on what we want to use it for. And so I want to go into a little bit of I don't know, is metaphor the right word for this? We're going to talk about cookies for a second because I want to make some points relevant to intellectual disability and autism. I promise you these cookies will be relevant to the topic. So imagine we have a chocolate chip cookie detector and a sample of cookies that are either chocolate chip or Oreos. Our cookie detector takes a bite and decides whether or not it's a chocolate chip cookie. She performed pretty well in this run. She caught 8 of 10 chocolate chip cookies, so 80% sensitivity, and she correctly said no to 9 of 10 Oreos, so 90% specificity. What this means is that if our test says the cookie is chocolate chip, she's correct 89% of the time. If she says it's not a chocolate chip, she's correct 81% of the time. That's the positive and negative predictive value. That's pretty good. But especially for the refined American palate, chocolate chip cookies and Oreos are really easy to tell apart, right? So we run another test where our chocolate chip cookie detector is asked to work through a sample of 10 chocolate chip cookies and 10 carob chip cookies. Carob is kind of like chocolate, but not. So this test is much harder, and we see that our tester correctly identifies 7 of the 10 chocolate chip cookies, so she's got pretty good sensitivity. But she only correctly classified 3 out of 10 carob chip cookies as not chocolate chip. So the sensitivity value is okay, but the specificity is pretty awful. And when we look at our positive and negative predictive values, we see that when our tester says a cookie is or is not chocolate chip, she's only right half the time. So, you know, what are we paying her for? So we're really starting to feel like we need to hire a new tester. We give her one final chance. This time, only about a quarter of our sample is chocolate chip cookies. So she performs the same test with the carob chip versus chocolate chip, and she performs about the same in terms of identifying the carob chip, which is to say not great. But her sensitivity to chocolate chips has improved. So she's got okay sensitivity. She correctly classified 2 out of 3. But this time, because the chocolate chip cookies were relatively rare, because we only started out with 3 chocolate chip cookies, our positive predictive value is only 22%. So that means that when our tester says it's a chocolate chip cookie, she's only correct 22% of the time. So you can see how altering the sample, altering the input that we were evaluating our test in, really dramatically affected our estimates of her abilities. And so I promised that these cookies examples would be relevant to intellectual disability. And so 1, it matters what the test is. It matters the sample that you're testing in because that's going to determine the estimates of of precision that you get out. Two, intellectual disability and autism are a lot more like chocolate chip and carob chip than they are like chocolate chip and Oreo. So autism and intellectual disability share many of the same symptoms and can be difficult to tell apart, as we've discussed. And the third thing I want to point out is that most people with intellectual disability do not have autism. So it's a lot more like this third test where there are only 3 chocolate chip cookies. We don't have great estimates of the rate of autism in ID, but it's certainly not the majority. And so the more rare an event is in a sample, the more difficult it is to have a good positive predictive value. The other more nuanced point generally about psychometrics that I want to make is about measurement invariance. So whereas with sensitivity and specificity, we were referring to measures in classical test theory terms, where the behaviors we're measuring are exactly what we're interested in. With many of the scales we use, we assume that we are measuring some latent construct, something that we can't actually see, by assessing behaviors that are caused by it. So in other words, it's not the behaviors that we're interested in per se, but rather the thing that causes them that we want to measure. We can't directly assess that thing that causes them, so we measure the behaviors instead. And most scales that we use are predicated on this idea. And so invariance then means that the relationship between these things that we can see, these behavioral indicators, and the broader construct that we can't see, the idea is that those relationships are the same across meaningful populations. So measurement invariance is really common in cross-cultural work. Does the measure look the same in Americans as it does in Chinese? And so, of course, because of what we're talking about today, we're interested, do we have measurement invariance between people with and without intellectual disability? And just like there are many different ways for a scale to be valid, there are several ways for a scale to have measurement invariance in increasing levels of difficulty. I'm just mentioning these terms to kind of familiarize them for you, but the gist of it is that, that there's sort of basic invariance, which is just whether the items are related to the construct in the same way between groups. But this last one, scalar, is the one we care most about. And a measure that has scalar invariance, what that means is that 2 people, let's say one with intellectual disability and one without intellectual disability, if a scale has scalar invariance, then 2 people who have the same level of this latent construct, social communication, will get the same score on the measure. Okay, and so of course we need that to be true if we are going to compare groups on a measure. We need people who have the same level of social communication in this example to get the same score on the measure that we are using to assess social communication. So if invariance is not supported, then we cannot compare scores between groups. It's really apples and oranges. And what's more, if we know that we are violating invariance, so if we know that the scale is working differently between people with and without ID, we cannot just adjust for it. It's not possible to kind of just like co-vary something out of the equation here. It's irreparable without altering the measure. And so if we continue to use the measure without addressing this lack of invariance, our clinical and scientific conclusions are going to be corrupted. So the key points I want you to remember as we next discuss the issues around the psychometric profile of common autism measures is that when we talk about reliability and validity, we're talking about a collection of things. So we have to be specific about what exactly we're talking about it. But more importantly, we need to be specific about the evidence we are using to talk about reliability and validity, because whether that evidence generalizes to the context you're using it in, and specifically here we're thinking about the people that you're using it in, that's a question that has to be answered. Not all psychometric evidence matters for your purposes. Finally, I want you to keep in mind that there may be serious, even fatal flaws in the psychometric profile of a scale that you can't necessarily nose out with your clinical good sense, or even with more basic types of analyses. So we need to keep in mind that the evidence base for the psychometrics of an instrument might be incomplete if those more nuanced questions haven't been answered. So we hear that the gold standard measures for autism diagnosis and the common measures that we use for autism severity have pretty good psychometric characteristics. If that weren't true, of course, they wouldn't be the gold standard. But this is why specifics matters. It turns out that our gold standard measures were developed in a very specific context. And that context matters because it means that the psychometric properties that we associate with these scales might not and do not generalize to all people. And so in order to determine this, we need to think about who is in the development samples, or more germane to this discussion, who is not in the development samples. So we know that people with intellectual disability are excluded from autism research in both systematic and incidental ways. And other work indicates that this rate has actually decreased in recent years. And this is a true test of, so this is true of test development samples as well. So it's not just an issue in autism research, it's also true in the test development, because these same forces are at work on test development samples, as well as changes in referral patterns, which affect the sample composition in test development. And so a corollary of this is really that by excluding people with intellectual disability from these development samples, we are also excluding people with physical impairments and sensory impairments, because these are more likely to occur among people with intellectual disability. And so in population-based research, we see evidence of this time and again. So we see here data from Scotland on the left showing higher rates of 3 types of disabilities among people with intellectual disability than among people with autism. And our study in the Norwegian MOBA birth cohort underscored the fact that when we condition on low IQ, we see far lower rates of delayed walking, which is, of course, an early index of motor impairment among people with autism than those without. Language impairment is also associated with intellectual disability. So in this archival multi-site study that you're looking at on the screen here, we documented that even among people with autism, the presence of intellectual disability is associated with much higher rates of minimal verbal ability. And I want to note that in many autism studies, when they use the term ID, they're referencing an IQ cutoff of 70 typically, but you can see here that the effect of intellectual disability on language level is definitely more pronounced when we're talking about more severe levels of impairment. And so all this is to say that the development samples that are used for our gold standard instruments and for instruments that we commonly use to assess the severity of autism symptoms are in many ways not representative of people with intellectual disability. And as a result, the psychometric profiles really do not apply. Even in the hands of experts, we can see pretty poor specificity of the autism diagnostic observation schedule and the autism diagnostic interview among children with nonverbal ages less than 15 months. And the test developers go so far as to recommend that the instruments be used cautiously or even not at all with children with very low mental ages. Low mental age is a problem for people with ID, intellectual disability, but would also be an issue for younger participants who are cognitively average. But we also see quite a bit of evidence that intellectual disability itself, as well as emotional and behavioral problems, which are more common among people with intellectual disability, are associated with poor specificity. So in this study, our collaborator, Alex Habdahl, documented that the specificity of the ADI was particularly bad, though, the ADOS, maybe owing to the enhanced role of clinical judgment, looked pretty good. So thinking back to the chocolate chip cookie test, most data are more like that chocolate chip versus Oreo study when the test or the sample that we're using it in is more like chocolate chip and carob chip. And so unsurprisingly, having good specificity in the development sample does not mean that the specificity is good in the sample when the test is asked to distinguish ASD in the context of intellectual disability. And finally, I want to touch on the issue of measurement invariance in these measures, which you'll recall is the extent to which the scale measures the same thing in the same way between 2 groups of people. So Alexander Sturm, who I think at the time of this publication was a graduate student, did a really great evaluation of the social responsiveness scale using Simon Simplex collection data, which is a big sample of children with autism. And I want to note that the social responsiveness scale is billed as a screening measure, though it's commonly used inappropriately, in my opinion, as a severity measure. And the authors repeatedly claim that it measures the latent construct of social communication in this like continuous normal distribution. So Stern did this really thorough analysis demonstrating that in fact 3 out of every 4 items on the SRS functions differently depending on at least one and usually a couple of these factors like language and IQ ability. And remember, when this is true, so differential item functioning is a form of measurement invariance. When that's true, it means that the scores from these groups are apples and oranges. So in the end, only 16 items met this invariance criterion and should be used. I also want to point out some work that we did in my shop demonstrating that this latent construct that's being measured here is not by the SRS is not actually continuous and normally distributed. And in fact, there probably is a lack of invariance between people with and without autism even, which is relevant to the extent that the SRS is being used in non-clinical samples. Okay, we've made it through the psychometric portion and I'm gonna wrap up with some clinical recommendations straight from the brains of my clinical colleagues. And I'm going to go through this a little bit quickly, only because we got started a little late and I want to make sure there's a few minutes left over. So when we're thinking about diagnosing autism in the context of intellectual disability, we want to make sure that we are thinking about exactly which social abilities or deficits we're observing. Not all are created equal. Some are more specific to autism than others, especially these more basic behaviors. The more advanced behaviors and impairments that we see in autism, like conversation, ability to modify behavior to match social expectations. These are things that are tend to be non-specific to autism and are likely also impaired in somebody with intellectual disability. We also want to think about, you know, whether these behaviors that we're seeing are commensurate with what we would expect based on the person's developmental level. I think I've belabored that point. We also want to think about the person's developmental trajectory because it's really unlikely that these deficits are going to pop up after the developmental period. But we also want to think about chronological age in terms of, you know, the timeline for the symptoms arising, but also in terms of modifying what we might expect for that person in terms of what their social behavior should look like. But knowing the person's developmental level is not the complete picture. We also need to take into account motor and sensory limitations, which we did not talk very much about. People with intellectual disability, as we mentioned, we saw some data to this effect, tend to have motor and sensory impairments at a greater rate. And this is going to directly impact your interpretation of the behaviors that you're seeing. And with all of that, we need to think about, given these impairments, you know, is it possible that we really are unable to judge whether these social impairments are commensurate with the developmental level? If that's the case, if it's not really applicable, that's not the same thing as evidence of an impairment. So we need to, you know, leave open the possibility that our assessment may be indeterminate. Similarly, if the client has a low cognitive ability or meaningful physical or sensory impairments, then we know, as we've reviewed, that the standardized assessments that are commonly used are potentially not valid for use in this individual. Sometimes I think people sort of think that that some information is better than no information, but as we've discussed, this information provided by these scales when used in the context of ID is not valid. And so, you know, I'd argue that bad information is not better than no information. And so we need to think about this carefully before we administer the test, whether it's clinically warranted. And we also, because people with intellectual disability have these complex presentations, obviously we all work in multidisciplinary teams anyway, but the multidisciplinary team may be particularly important for intellectual disability to help us think about all the different aspects of psychological, medical, neurological, motor, sensory issues that are likely happening in these individuals. So these are, I'm gonna actually skip over this because I understand that you guys will have the slides available to you, and that's just kind of repeating what I've already said, because I wanna have a second to summarize and say that, you know, what I hope you'll take away from this hour that we've spent together is The accurate diagnosis of autism in the context of intellectual disability really is important for both clinical and research reasons. And it's difficult to do, both because the behavioral distinctions are nuanced, but also because our assessment tools really are not robust in this respect. And so to appropriate the old aphorism, you know, tests do not diagnose people, people diagnose people. So your clinical judgment is essential, and it cannot be replaced. We cannot use these measures without really thinking about what we're doing with them. But more broadly speaking, we have to remember that the psychometric properties of an instrument really need to be evaluated with care each and every time we use it in a new setting. Is the information we know about this scale relevant to the group we're using it in? Too often for people with intellectual disability, the answer is no. The information we have is not relevant. And as a field, we really need to focus on rectifying this gap. So I want to say thank you to my collaborators, to whom I am greatly indebted. And you can see my email on the screen there. You are welcome to contact me with any questions, or if you want to be brave and ask a question now, I suppose the floor is open. Leslie, is that what happens? I'm going to stop sharing here.
Yes, absolutely. Thank you. Thank you. So either by chat, or if you want to say any questions or comments. And thank you very much, Dr. Farmer, for reviewing that. It's really interesting. I'll start with a question, and this might be a hypothetical question, so take it with a grain of salt. But what would you recommend to someone who might be part of that planning and implementation of services group, but wasn't part of the assessment process, doesn't have much information about ASD versus ID, does have a clinical interview and some background? What would you advise to that person? How would you guide that person? Because I think it's important. What you've laid out is really important, and maybe something that clinically we're not including as a consideration. But where do we start if we don't have the assessment piece?
Yeah, I mean, I think that that's a really good question, and one that I'm probably not equipped to answer. And I think it highlights the kind of the sequela of the problem, right? Because I was largely talking about, like, in this diagnostic context, when the person is in front of you and asking, you know, is the autism diagnosis appropriate? You know, depending on what happens there, that person is routed, right? And they may end up in front of you. And I think if I understand you correctly, you're saying, well, you know, here's this person, the team's already made a decision. How can I sort of determine whether that's right? And, you know, I think that, I think that's an excellent question. I don't know that, this is probably going to be heresy. I don't know that, like, standardized assessment, you know, is 100% necessary for a global understanding of a person, but I do think that having the mindset of having a global understanding of the person, so not just asking about autism symptoms or, you know, whatever it is that you've been charged with dealing with, but rather thinking more broadly, could maybe inform that. But you can tell by my rambling, I don't have a great answer for that. I think it's a really, really good question, and something that we need to think about as an inevitable result of lack of specificity and diagnosis, that it's then putting people in a bind later in the process.
You know, I appreciate it. I really like the balance scales. Visually, I thought that was effective in the beginning of your talk. And I just wonder if there was, if we continue to observe behaviors and development over time, if it starts to outweigh on one side or the other, if that might be a way. But
yeah. Well, and I think something that you just said was observing it over time. I think that, you know, we study developmental disorders, right? And the idea that you can get a great sense of what's going on in a developmental disorder by seeing a person once doesn't make a lot of sense. And so I think you're spot on with thinking about, like, what's happening over time. And that's really going to inform your interpretation of the relative impairments, I think.
So Regis noted that he appreciated your chocolate cookies analogy. It makes sense.
Thanks.
I have a question, and I'm not entirely sure how to articulate it, but in terms of interventions, in terms of treatments, and parsing out the difference between ID and ASD, assuming that assuming it has to be parsed out, like we're not really sure with a particular individual, are there already treatments, are there already interventions that are going to be beneficial to somebody like that we had to parse out with, or is this a mechanism to start developing new treatments in and of itself?
That's such a good question. And I think it's sort of what I was thinking of, you know, because I do mostly statistics and psychometrics, I'm used to thinking about details about things that other people are like, who cares about that? That's so esoteric. And I think that, you know, in one way of thinking about it, this distinction, it could fall into that category of thinking like, well, who cares? Because it's not like we have, you know, a big list of effective interventions for autism that are not effective for intellectual disability, right? So from that perspective, you know, and that's kind of what I was meaning to discuss when I mentioned ABA. Like from that perspective, like this might not be meaningful, you know, from
Right.
like on the ground, like, but it, you know, because I'm really largely in the research world and thinking about how this is going to kind of affect things research wise, it matters to that extent. It matters, and like you said at the end of your question, it matters to the extent that we may develop interventions that are specific, because obviously then it would matter. But I think you're probably right that at this current time.
Well, I think it can be kind of a chicken and egg sort of situation, is that, you know, do we really try to make distinctions for something that we don't have a treatment for?
Yeah.
You know, so maybe we're on the cusp of that. I don't know.
Yeah, I think that's a great point.
I had a question. So something that really stuck out to me that is apparent in my training as well, with music therapy, is that if we are trained in or more familiar with a certain thing, we tend to kind of go with it either implicitly or explicitly. I'm wondering if there's any other research about potential biases from practitioners that might lead to some of those assessment making decisions.
That's such a good question, and I think it's spot on. I don't know if anybody knows off the top of their head of examples of that work. I don't off the top of my head. My experience is that people who study autism tend to see autism everywhere and diagnose it everywhere and have the sort of biases when they're looking, you know, seeing the same result. And so that's one of the things that we really focus on is this multidisciplinary team, because somebody, you know, like yourself with a different viewpoint than me might be looking at the same information and come to a different conclusion. I think that's such an important point.
It almost kind of reminds me of Maslow's quote, if the only tool you have is a hammer, you tend to see everything as a nail. Because the reason I ask is I know something in music therapy, especially with this pandemic, is somebody referred to it as McMarketing. Of course, not all of us intend to do that, but doing a kind of diagnostic or even prescriptive analysis in order to prescribe a certain treatment. So wondering if even like the selling of a treatment is the impetus for an assessment. I mean, that was brought up in a group that I'm in, like talking about ableism and you know, disability theory. What are we really assessing? Like, what is the purpose of it?
Yeah.
But yeah, I just wanted to know if there's any research out there about clinical biases assessments.
Yes, I think like I said, I'm sorry, I'm not, I don't know off the top of my head, but I know it exists.
All right. No, that's
a great,
no,
great
thank
question.
you.
Yeah.
Any other questions or comments for the chat? All right, well, it's a little after 2. Dr. Farmer, thank you again for presenting your work. It was really interesting. We appreciate
Thank you. Thank you for having me. Nice to see all you guys.
You too. Take care.
Bye.
Bye.